All right, good morning, everyone. Thank you all for joining us this morning for Emory Healthcare's Health and Wellness Speaker Series for DeKalb County School District employees. We are excited to be with you all in this month of April. We have a really great talk lined up on cardiovascular health from one of our primary care providers, Dr. Kristi Kinsey Gotier. She is an Atlanta native. She attended Georgia Tech for her undergraduate degree and then the Medical College of Georgia for med school, where she then, upon graduation, entered the Air Force. She completed both her residency while being in the Air Force and also served as a staff physician for a bit there. We are now lucky to have her as one of our primary care providers at our Emory at Stonecrest location, and we are super excited to have her here with us this morning. So I'm going to pass it over to her to kick us off.
Thank you, Lindsay. Thank you, everyone, for joining. I'm excited to talk to you guys about cardiovascular health today. I am a primary care physician. My office is located in Lithonia, and I'm internal medicine doctor, meaning that I see patients ages 18 and over and deal with all primary care issues. So I see a lot of patients with hypertension, diabetes, chronic kidney disease, high cholesterol. So this talk is timely on cardiovascular health. See if I can. There we go. So what exactly is cardiovascular disease? So it's a compilation of a lot of disorders within the heart and the subsequent blood vessels that it supplies. So it consists of coronary heart disease, which would be the heart of this talk today, including the blood vessels that supply, obviously, the heart, and includes heart attacks, heart failure, stroke, and heart failure. Then there's cerebral vascular disease. Those are the disorders of the blood vessels that affect the brain, leading to stroke. Peripheral arterial disease, which is the disorder of the blood vessels supplying the arms and the legs. Then there's rheumatic heart disease, a disease of the heart vessels that comes on from having rheumatic heart fever. And then congenital heart disease, which usually deals with malformations in the heart that exist at birth. So a few facts about cardiovascular disease in general. It is the leading cause of death in the United States for both men and women. Causes more deaths than even cancer, if you can believe that. Almost 700,000 people have died for heart disease, and that was as of 2021. And then every 33 seconds, a person dies from a cardiovascular event. And from 2018 to 2019, approximately $239.9 billion was spent on deaths from cardiovascular disease, and this included hospitalization, medications, and then loss of time from work due to the cardiovascular event. So a few more things is that almost 50% of cardiac deaths occur even before the patient gets to the emergency room. And that's what kind of led to the advent of having AEDs in public places, like churches, schools, public events like sporting arenas. So that's kind of to help get that number down. And then what we're going to talk, the bulk of this talk is about the 80% of coronary heart disease could be prevented if we could just modify certain risk factors. So we'll be talking about that as well. So coronary heart disease, which is what I'm going to focus this talk on, leads to myocardial infarction, which is just our fancy medical term for heart attacks. Chronic angina pectoris, which is chronic chest pain, hypertension, which is also synonymous with high blood pressure. It can lead to stroke and it can lead to heart failure. But this talk, we're going to focus just on heart attacks. So just to give you a little bit about the anatomy of the heart sits in the anterior chest, kind of toward the left side of the chest wall. It is a muscle. It also is about the size of an adult fist. And it's composed of 4 chambers, the 2 upper chambers called the atria and the 2 lower chambers called the ventricles. And this just depicts kind of the blood flow of the heart through the lungs to the rest of the body. But we won't go into that any further than that. So because the heart is a muscle, it definitely needs blood flow and oxygen to work, right? So, and we also have to exercise it because it is the muscle. Because if you don't exercise it, right, what happens? It becomes flabby. The chambers get big, or what we call hypertrophy. And so then they don't work as well to help pump that blood through the rest of the heart and to the rest of the body. And so then that causes issues like heart failure, heart attacks, and you name it. And so when you don't so when you stop the blood flow of blood through the heart too, over time, if it's for a short period of time, then that causes kind of the heart muscle to die, and that's kind of how part of how a heart attack occurs. So heart attacks are usually acute events, as I said. So that's why it's very important that you get to a person in the first few seconds to minutes of an event. It's caused by the buildup of fatty deposits that we call plaques, and these, which is made up of fat, cholesterol, and debris. And over time, these plaques can just keep forming and forming until they occlude the blood vessel or artery, and then that prevents blood from flowing to the heart, which causes the heart attack. So what are some of the causes of coronary heart disease? And we're going to talk about unmodifiable risk factors and modifiable risk factors. So the unmodifiable risk factors are risk factors that you can't change. So you can't change when you were born, right? You can't change your family genes, the family you were born to. So age and family history are very important risk factors for coronary heart disease. If you have a first-degree relative who has had a heart attack or stroke or whatever, then you're at increased risk for having those same things. So we're going to talk about how you can change that scenario. But first, let's just talk about the age. So typically we see that men ages 55 years or older are at increased risk for having a heart attack. And then women typically is age 65 or over. But now we're seeing patients as young as 20 years old having heart attacks. And some of that is congenital. So they have some coexisting issue that they were born with. Some of it is diet, because we're seeing that our population is more obese. And so we're seeing it a little bit more in our younger ages as well. And then that has to do with some of the other comorbidities that people have as well. So, if you have hypertension, diabetes, you have high cholesterol, then that puts you at increased risk as well. Also, we typically see a little bit more in men than women as far as heart disease is concerned. And then there's a little spike in women once they become menopausal. So that average age is, menopause can occur anywhere between the ages of, the average age is 51, but it can occur before that, or it can occur as late as 55, 60. So once that woman meets the menopausal status, which is after they haven't had a cycle for 1 year, then that puts them in a little bit increased probability of having heart disease, but then that kind of equals out after that period of time. So what about the modifiable risk factors? So these are the risk factors, that 80% I was talking about, that we can do something about and try to prevent. So the first one is hypertension, which is high blood pressure, diabetes, hyperlipidemia, which is high cholesterol, and then smoking. And we're going to go one by one through these risk factors. So again, almost 50% of adults have hypertension. That's almost 120 million people, and this is in the United States. I will tell you that there are another bulk of people who have it, who know that they have it, but are not doing anything about it. I can't tell you the number of times that people have come into our clinic feeling fine, no symptoms at all, and their blood pressure was 180 over 100 or 200 over 120. So I see that kind of on a regular basis, and that's why we call it the silent killer. So this is something that we need to really get on top of. You do see a little bit more hypertension in men compared to women. It's definitely more common in non-Hispanic Blacks. And then the threshold for hypertension now has changed. As of 2017, we changed. It used to be that blood pressure was defined as any blood pressure 140/90. Now it's a blood pressure, anything greater than 130/80 on 2 occasions, we can classify you as having hypertension. And we do know that, there's obviously a lot of costs with patients who do have hypertension, as with medications, and then all the things that can come after having uncontrolled hypertension over a long period of time. And so that's something that we really can kind of get a handle on. So then diabetes. So both diabetes as well as prediabetes is associated with premature heart disease. You're about at 2 times the risk of having a heart event if you have diabetes. So we try to get people at the pre-diabetes stage. We definitely talk about, kind of diet and exercise to help you even prevent you from getting to the diabetic stage. Like I said, as you see the numbers, almost 40 million people in the US have diabetes, another 98 million have pre-diabetes. So if we can get to that stage and get you before you get to diabetes, we probably could prevent a lot of coronary events. It's definitely the 8th leading cause of death in the US, which is pretty high. And so we define diabetes as any random blood sugar that if you have a lab test, just randomly, you can not be fat, meaning that you have eaten, then any blood sugar greater than 200 is considered diabetes automatically. And then if you have 2 fasting blood sugars greater than 126, then that's considered to be diabetes as well. The other marker that I didn't put on this, I neglected, I'm sorry, is the hemoglobin A1C that we harp on, and that's a measure of your blood sugar over a 3-month period of time. If that is over 6.5% or above, is considered to be diabetes. Pre-diabetes is anywhere from 5.7 to 6.4%. So we typically, physicians, providers, kind of treat this a little bit differently. So some providers would go ahead and start treating you at the pre-diabetes range. I tend to give you a chance to kind of work on your diet and exercise, and we'll treat once it gets to a little bit of before it gets to 7%. But like I said, you have a 2 times risk even with prediabetes of having coronary artery disease. So definitely you want to get on top of that. And we've seen the prevalence of diabetes go up and up and up and up. And some of that is because of this, obesity revolution that's going on. So we definitely need to get on top of it, especially for our young ones who we're seeing being more obese than generations before. And it's just getting worse and worse. And so that means that you're at increased risk for some of these things we're talking about: hypertension, diabetes, high cholesterol. So high cholesterol definitely also puts you at more risk for having a coronary artery event. I will tell you that providers, sometimes we will start treating you for cholesterol, even if your cholesterol is not high, especially if you have diabetes. The consensus is that you should still be on a cholesterol medication to help prevent that buildup of plaque we talked about that can lead to a cardiac event. If you had a stroke and you didn't have any, and your cholesterol is normal, we still recommend, for the same reason, to prevent that plaque buildup. Because a lot of patients will ask, well, why am I on a cholesterol medicine? My cholesterol has always been good. But we do that preventatively for people who've had stroke, people who have diabetes especially. And most people, I would tell you, who have high blood pressure, a lot of times it goes hand in hand that their cholesterol is also elevated. But again, so cholesterol is usually a panel, right? And so we call it the lipid panel. You may know it as the lipid panel. There are 4 entities to that. So there's the total cholesterol, the HDL, which is good cholesterol, the LDL, which is considered the bad cholesterol, and then triglyceride level. So any level of total cholesterol over 200 is considered too high. And HDL less than 40 is considered too low. So you want the good to be as high as it can be. So for women, typically we want that level to be 50, 60 and above. For men, we'll settle for 40 and above. The triglyceride level, which is also a type of fat that comes in the diet, if that level is greater than 150, that's considered too high. And then the LDL, which is considered the bad cholesterol, if it's greater than 160, then that's considered too high as well. But it also depends on your risk factors. So if you're already known to have diabetes, then your goal is to be less than 100. And then if you have had a heart attack already and have coronary artery disease, and your goal for your bad cholesterol should be less than 70. But most people just normal who don't have those comorbidities, then as long as it's less than 160, then you're okay. But to be truthful, most providers are trying to get you to close to 100 as possible, just to kind of get you out of that risk for heart disease. And so smoking. If you don't smoke, don't start. But if you smoke, then you probably need to stop. It increases the risk of heart attack and stroke by 2 to 4 times. Over time, smoking damages the blood vessels, it elevates the blood pressure. And so obviously all of these put you at greater risk for having a heart attack. And we do know that if you quit, you can restore your risk of having heart disease to that of a non-smoker after stopping for 15 years. So I would tell people it's never too late to try to smoke. Even if you stop for, each year that you stop, you decrease your risk for having heart disease. So definitely stop smoking. And so there are some what we call intermediate risk factors. There are risk factors that probably promote the risk of having heart disease, and obesity is one of those that we have talked about before. So, obesity, especially in medicine, we kind of look at what's called the body mass index, or BMI, and that's calculated by your weight in kilograms over your height in meters squared. And so anything over 25 is considered to be obese, and anything over 30 is considered, anything over 25 is considered overweight, and then anything over 30 is considered obese. And so we know that decreasing your weight, working on your diet and lifestyle modifications, as I call them, will definitely help. So we know physical inactivity, so being sedentary is another risk factor for heart disease. So the more sedentary you are, the more you're not using those muscles. And when you don't use them, you lose it, we call it. So those muscles atrophy and get weaker. And so that's why exercising, and we say, which we'll talk about, exercising 4 to 5 times a week for 30 to 45 minutes a day is considered at moderate intensity is considered effective exercise. So there's something called microalbuminuria, which is just a fancy term for microscopic protein in the urine. So when you come sometimes to your doctor and get just a regular urine dipstick, we can see protein sometimes in the urine. And so you can get protein for different reasons. We definitely see it in patients with diabetes. We sometimes see it in people that have uncontrolled hypertension. We also see it in people who have chronic kidney disease. So we're thinking that this could be a prominent risk factor that makes you at more risk for heart disease as well. And then there's some inflammatory markers. We don't get these routinely. Sometimes we don't get them until after we suspect that a patient may have had a heart attack or a stroke. So one is called the homocysteine level, the other was the C-reactive protein. There hasn't been a causal link necessarily, but we have seen that some patients have increased levels of these two proteins. But again, we don't necessarily do them routinely yet. And so what are the symptoms of coronary heart disease, right? Or heart attack? So obviously the most common is chest pain. The chest pain is described as a pressure, squeeze, and fullness. A lot of people liken it to an elephant sitting on their chest. That pain can radiate down the shoulder, to the jaw, to the arms, to the upper back. Can be associated with dizziness or lightheadedness, shortness of breath. Some people break out in a cold sweat. You also have nausea, vomiting with it, and then just appearing really pale. Can also be some of the symptoms of a heart attack. Typically, these symptoms come on with exertion, but sometimes people can have them at rest, but usually it lasts for a few minutes to half an hour. So if you have any of these symptoms, you're over 50 and you have the risk factors we talked about, you have high cholesterol, you have diabetes or hypertension, then don't take those symptoms lightly. You probably need to be seen in the emergency room. Now, women can sometimes present atypically. Sometimes they don't have the chest pain, but they have more of the shortness of breath. And they may have more typical signs of heartburn and indigestion. So that's why sometimes it's hard to determine whether you're just having reflux type symptoms versus a heart attack. But again, if you're in that high risk category and you're over a certain age, then you should think it's cardiac until proven otherwise. So then when you are seen in the emergency room, let's say, and what do they do to help diagnose a heart attack? So definitely there are a series of blood tests that are done. So the heart emits enzymes when the heart has been damaged. So we definitely look at those cardiac enzymes, and they look at a series of 3. So they do them, I think, every 30 minutes to an hour to see whether those enzymes are raised. You also want to look at the patient's blood sugar, of course, their chemistry profile, including the sodium, potassium, calcium levels, cholesterol levels, and obviously A1C if you know the patient is diabetic. So you definitely want to go through those series of tests. And then obviously one of the more important things is the electrocardiogram, called the EKG, where it's basically a snapshot in time. It's just 1 second in time when the heart is beating to determine if there are any changes. So this right here is kind of what a normal EKG would look like. But there's certain things that we look at that can determine. So we also look at the heart rate. Is it too slow? Is it too fast? Look at the heart rhythm. Is it normal like this, or is it abnormal? So we know the atrial fibrillation is a big risk factor for people with stroke. So, but anyway, abnormal heart rhythms, that's what we're looking for with the electrocardiogram. That can give us a lot of insight into what's going on in it. And then in addition, the cardiologist may ask for an echocardiogram, which is an ultrasound of the heart, kind of looking at the structure of the heart and the valves of the heart, trying to see if you have a leaky valve or if a valve that's too stiff. And then, kind of if there's obstruction in the blood flow, so that can all tell that as well. And then the stress test is one of the definitive tests to determine whether we need to do a heart catheterization. So with a stress test, if you can exercise, then we prefer that. If you can, then we put you on a treadmill, hook you up to the EKG monitor, and then we exercise you, trying to simulate chest pain or something abnormal on the EKG. If you cannot exercise, then there's something called the nuclear stress test, and that's where we inject a dye through the IV and simulate. It's a medicine that simulates like you're exercising, because it tends to cause people to feel a little weird and like they've exercised. And then we do some scans under fluoroscopy or ultrasound, and we do scans before and after giving the medicine, and that can determine if there's some blockages in the heart as well. And if you do have blockages, then the end result is to have a heart catheterization. And that's where they put a catheter either in the groin through the femoral artery, but more commonly now we do it through the wrist, through the radial artery, and that catheter goes up into the coronary arteries looking for plaque buildup and obstruction. And then we can inflate a balloon that flattens that plaque, and then insert a stent, which helps to keep that vessel open now and improve blood flow that way. But there are times when depending on where the blockage is, it's not amenable to stenting. And so in those patients have to actually have open heart surgery and bypass surgery. So what's the treatment once you are diagnosed with a heart attack? Most patients will go home on multiple medications. So aspirin, a blood thinner to keep the stent in the artery open, cholesterol medicine, blood pressure medicine. And if you have diabetes, obviously, you want to make sure you're controlling that. So yes, you definitely got to control the blood pressure, because the lower the blood pressure, the less the heart has to pump and the more blood flow is improved. Definitely want to improve that cholesterol, as we talked about, because you really got to, you're trying to get to that plaque that builds up. Controlling diabetes, as we talked about, diabetes is a big risk factor for heart disease. And then obviously getting the patient to quit smoking. And obviously there are things, so we got lots of things just going back to, so with high blood pressure, the main thing we harp on in addition to medication is lowering your sodium intake. So not just salt that you add to food, but sodium, which is in everything. So you got to look at your fried food intake, your fast food intake, processed foods, packaged foods, microwavable foods, canned foods. So you're looking at that, and the number for you is to have less than 2,000 milligrams a day. So low sodium diet and medication. Cholesterol, we do harp on the diet as well. So less fried foods, less red meat, more fruits and vegetables, of course. And then if you can't do that by itself, then the medicines that we give in the class of statins you probably have heard of. Then we give you the statins. Now, obviously, there are some people who can't tolerate statins due to muscle pain. And the muscle pain is real, but I will tell you that most of our patients can tolerate statins, but we do change them if you do complain of muscle pain. Sometimes we change you within the class to another statin that causes less muscle pain. But if not, there are other medicines out there now. So there's Zetia, there's cholestyramine, there's some phenylfibrate. So there are other medicines. There are also, you got your supplements out there, omega-3 with fish oil that you can use if you have low level of cholesterol and just can't tolerate statins. Some people do CoQ10, some people do niacin. So there are some other supplements out there you can try. And of course, with the diabetes, now we have those new injectables out there, Ozempic, Mounjaro, Wegovy, Zepbound. It's easier for the people who have diabetes to get those medications. I'm gonna tell you that right now there's a back order, especially on Wegovy and Mounjaro. So other patients who just want to lose weight are having trouble getting those, or even getting approved. And those who get approved, it can be a little pricey, but they do work well for most patients. And then obviously there are medicines to help you quit smoking, right? So there's Chantix out there that we use as a pill. There's bupropion also, which was originally anti-anxiety, antidepressant medicine that we use for some people to help them quit smoking. But if the medicines don't work, then obviously you still have the patch, and then there's gum as well to help. And then also the other prong is to, we want to just kind of try to get you to exercise and be active and healthy, right? So, like I said, being sedentary increases your risk of having heart disease. Like I said, want to focus on eating healthy and heart healthy diet with more fruits and vegetables, less fried foods, less meat. The Mediterranean diet, which is a plant-based diet with vegetables and grains, has been shown to be a great diet to help achieve, or decrease your risk for having heart disease. Drinking more water. So we say, of course, 64 ounces a day or more if you can tolerate. So some people would say even 100 ounces a day of water is good. So the more water you drink, the more full you feel. And obviously it just helps with overall functioning of the organs in general. Achieving and maintaining a healthy weight, of course, and then managing your stress, which we don't talk about. And so stress is a big risk factor. So we know that the more stress you have, sometimes that correlates with elevated blood pressure. It also can correlate in my patients who have diabetes and they have stress, we notice that their blood sugars go up. And then sometimes if you have more stress, then you tend to eat the wrong foods, which obviously leads to weight gain, which then just increases that cascade of events that causes a heart attack or stroke. So in summary, we've learned hopefully that cardiovascular disease is the leading cause of death in the United States for both men and women. Under the umbrella of cardiovascular disease, heart attack and stroke are the most common. A lot of the risk factors that we talked about, high blood pressure, diabetes, high cholesterol, smoking, can be prevented, modified in a way that can decrease your risk of having heart disease. We talked about a heart healthy diet and lifestyle modifications, so that exercise 4 to 5 days a week for 30 to 45 minutes at a time at moderate intensity can help. Maybe a Mediterranean diet or just a diet low in cholesterol, low in sugar and carbohydrates, and low in sodium can help. And if you can't do it by yourself with the diet and exercise, then yes, there are medications that we do use that will help that as well. And I always want to just put a plug in that everybody should get a regular physical exam at least once a year, right? And that's your preventative visit where you can talk about, medicines that I may need, vaccinations, do certain tests, what lab tests do I need to even help prevent cancer, right? What cancer screening? So your mammogram, colonoscopy, um, CT chest scan if you're a long-term smoker. So there are definitely preventative things that we need to do just to keep ourselves on track. And I know schedules get busy. We got working parents, but you got to take care of yourself before you can take care of everyone else. And it's also a time just to have a good, hopefully you have a good rapport with your physician where you can ask them any question that you have. If you can't, then you probably need to find another doctor. But I will say that for my patients that have high blood pressure, diabetes, high cholesterol, those patients I see a little bit more frequently. So if I'm adjusting medications, I may see my patients with high blood pressure once a month until we get it stable. My diabetics, I see initially every 3 months until they get stable. Then I go to every 6 months. Definitely my patients with high cholesterol, if we're adjusting in every 3 to 6 months as well. But it's just important because some people will say that, oh, I feel fine. I feel good. I don't have any problems. I exercise. And that's all well and good because we want you to do all of those things, but sometimes things will sneak up on you. And like I talked about, blood pressure, high blood pressure can be a silent killer. And even diabetes, some people don't have signs or symptoms at first, and they can be going around with uncontrolled hypertension for a long period of time. And we know that the longer you let those things go, then they can affect all parts of the body. I always tell my patients that diabetes and hypertension can affect the brain, leading to stroke, right? Affect the heart, leading to heart attack. It can affect the kidneys, leading to renal failure, leading to dialysis. They can affect the eyes, leading to blindness, and they can affect the nerves, leading to something we call peripheral neuropathy, which is that burning pain sensation that can be very awful in the arms and legs. And so yes, you can feel good. I'm glad to hear it, but definitely still go to your doctor once a year, just to be checked, just to make sure, okay? And so that you don't get surprised one day if you go in and then there's a number that's elevated and you can't do anything about it. So we want to be preventative in that way. So thank you again for your time and listening. I hope you learned a lot from this talk. And at this time, I will take any questions.
Wonderful. Thank you so, so much. It looks like we actually already had a question come in through the Q&A. But again, just as a reminder to everyone, you can use the Q&A function, you can use the chat function, and then I am going to slowly work through giving you all the permission to mute and unmute yourselves if you'd like. And so it looks like the first question we received, somebody said, they were recently informed that they have a heart murmur. Does that increase their chances? They were placed on a 90-day blood pressure medication and now have lower blood pressure, and they don't want to continue blood pressure medication, but stress is difficult to keep down, started exercising more to cope and share experiences.
So thanks for the question. So just having a heart murmur doesn't necessarily increase your risk of having a heart attack or a heart event. Some heart murmurs, some people have at birth. So there are some benign heart murmurs, but there are some heart murmurs that make us think that it could be something else. So especially with the heart valve. So the only way to really confirm that is to have an echocardiogram, that ultrasound of the heart, to determine whether it's something to be worried about or not. But sometimes people just have heart murmurs and that's normal. We know they have heart murmurs and they've been assessed by cardiology and it's benign, and so we just kind of follow it. But like I said, some heart murmurs can be due to aortic valve stenosis, mitral valve prolapse, or mitral valve regurgitation. So that's where the echocardiogram comes in. Now, I'm not sure. So just having a heart murmur doesn't necessarily make you hypertensive either. So I'm assuming that your blood pressure was elevated and that's why they put you on blood pressure medicine. I always tell people that we can't determine whether it's typically once you have high blood pressure, it is indefinite, but there are patients that I sometimes can take off blood pressure medicine if I see that their blood pressure is getting lower and lower and lower. But that's something that's why you have to go to your doctor to be seen regularly to determine whether you can get off of it or not. Some patients can, some patients cannot. But I'm glad that you're exercising to help with the stress. Some people, I say, if you don't know when your stress level is gonna go away and your blood pressure is still elevated, that it's safer to be on blood pressure than not. I know patients have a trouble with wanting to be on medications, but I tell them it's not the worst thing, unfortunately, and you'd rather be around and not have a stroke or heart attack. So again, you just got to talk with your provider and get repeat blood pressure readings to determine if you can get off of that medication.
Awesome. So it looks like we also just got another question in the Q&A. Somebody said they have AFib and they were told they have to take meds for the rest of their life, including blood thinner.
Yeah, I can speak on that.
Is there a fix for that to do where they don't have to continue taking these meds?
So unfortunately, there is no fix right now. So atrial fibrillation is where the top part of the heart and the bottom of the heart are not in sync. And so what happens is when the blood pumps from one chamber to the next, it doesn't pump it all the way. So some blood is left back behind and it grows stagnant and it can form a clot, which then causes a heart attack or stroke. So that's why we put patients on blood thinners for that. And unfortunately, it is indefinite, so typically lifelong, because your risk of stroke, after having AFib, your risk of having a stroke increases 1% every year. And so that's the reason for the blood thinner. And then also sometimes we put patients on rate control medicine, meaning we got to keep the heart rate down so that the heart is not pumping as well. And some people are on what we call antiarrhythmics to kind of keep the rhythm in the normal rhythm instead of that atrial fibrillation rhythm. But that's the reason for the blood thinning. Usually, unfortunately, right now it's indefinite. But that's the reason why, at least you know why you're on it, is to help prevent the stroke.
It looks like, let's see. Checking the Q&A and the chat. Any other questions, comments?
And anybody can ask anything, what's related to hypertension, diabetes, stroke, kidney disease. Kind of what I see every day, day in, day out. Any questions about the weight loss supplements out there? Because that's a big hot topic right now.
So someone just typed in the chat, they don't have a microphone, but they would like to find out what are the parameters for patients who have heart disease, had a stroke, or hypertension to be able to take Viagra or Levitra. So many men do not want to take or continue meds due to sexual malfunction. They're a nurse and would like to know how to handle that.
So yeah, I always tell my patients, especially the males, that it's not just not the medicines that cause the erectile dysfunction, right? It's also just having the disease entities in the first place, right? So hypertension affects the vessels, even going into the reproductive areas. So having hypertension, having diabetes, all that, if you can get that under control, sometimes that will improve erectile dysfunction. But yes, we do know some of the medicines do as well. But just so you know, it's a catch-22, is the disease process as well as the medications. So the only contraindications to using Levitra or sildenafil, which is Viagra, is if you're on a nitrate or not. So that's nitroglycerin or isosorbide nitrate. So if you're on any of those, then we typically don't, because it lowers the blood pressure too much and you can't control that. Obviously nitroglycerin, you're not taking every day typically. So if you're not taking, you don't take it if you're going to use those supplements. But otherwise, there are really no other contraindications that because we prescribe it all the time. And so, like I said, just being on a nitrate is usually the main focus of not being able to take it.
Now we have a handful of questions coming in on the Q&A. Somebody asked, do you recommend certain exercises for the heart, like walking?
So yeah, the exercises, yes, include walking, jogging, you can walk on a treadmill, elliptical cycle, and then swimming is a good exercise. Those who have, which I failed to mention, if you have, let's say, arthritis pain, because I see a lot of patients with arthritis, and so they have trouble exercising due to the impact on the joints, then water aerobics is a great low impact exercise for those who have arthritis. So some of my patients swear by it. So if you have, is there a rec center that has a pool, or, obviously LA Fitness, some of the Ys, then yeah, water aerobics is great, but just swimming in and of itself. But yeah, swimming, walking, jogging, those are the main ones. And even a recumbent bike, cycling on a recumbent bike is good for exercise.
We got another question. Somebody asked, are varicose veins and blood clots common enough to be placed on blood thinners?
So varicose veins and blood clots are two different things. So varicose veins are just those protuberant veins that you see that are enlarged sometimes on the legs, and even up to the thigh. And so some of that comes from just occupational hazard. So standing on your feet for long periods of time, if that's what your job requires for 12 hours on end. So that's where compression socks and stockings help with that. And then sometimes just cold compress hot or heat to help kind of with the pain, or taking ibuprofen if you need to. Blood clots are a whole different entity. Now, blood clots do come sometimes from being too sedentary, being overweight, or having surgery or trauma, right? And so blood clots can emanate from the veins in the legs, or you can get a blood clot to the lung, which is a pulmonary embolism. And so that's a different entity, and there's no rhyme or reason other than, like I said, the risk factors of having a surgery. So that's why you see it commonly after orthopedic surgery. So people have knee replacement surgery, hip replacement. The doctors now tend to put you on prophylactic blood thinners before to help prevent, but I still had a few patients who still had one after the fact. And then pulmonary embolism, you can just see them sometimes in people who have pneumonia or things of that nature. But just know varicose veins and blood clots are not synonymous.
And then similarly to that, I believe it was the same individual who also asked, they do take Bayer aspirin daily. Is that considered a blood thinner?
So aspirin is considered a very mild blood thinner as such, because obviously it can cause, for some people, over a long period who take it over a chronic period of time, but usually excessive use can lead to GI bleeding or bleeding in the GI tract. But it's very mild, so Bayer aspirin is okay. So that's usually 81 milligram tablet, but there is a 325 milligram tablet of aspirin as well, but the baby aspirin. So we used to, and so this just changed maybe 3 years ago, where we used to have all our patients who were diabetic and hypertensive on a Bayer aspirin, a baby aspirin, just prophylactically. And so there was a study that came out that said that it didn't decrease or increase the risk. So they felt that patients didn't have to be on it any longer. And so now it's not anything that we do on a regular anymore. But I mean, it's not harmful, let me put it that way, but it is a very mild blood thinner, yes.
We got another question. Somebody asked, can plaque buildup be reversed?
So that's a great question. So typically once it's there, but that's why, but possibly a little bit, that's what some of those medications can do. And that's just what a good modification in your diet can at least prevent it from getting worse. Because if we probably looked in everybody's coronary arteries, there's probably been some plaque buildup, even in maybe our 20-year-olds, right? But that's why we harp on that diet and exercise and modifying that. We can at least stop the progression. But whether it can be really reversed, the only way it's really reversed, right, is when the patient undergoes a heart catheterization and they flatten that plaque for you. that's maybe a way to, but typically, other than that, no, it's just diet and exercise to help prevent the progression.
We received a message in the chat. Somebody said they have 2 episodes of blood clots, which resulted in a PE. What are the odds of a 3rd event? Eliquis is their current treatment, and they were not able to locate the origin of the clots.
So yeah, that's where Eliquis is going. So typically, obviously, the blood thinners are to help prevent another clot from forming. So Eliquis is a great drug to, I mean, that's something, yes, you're gonna have to be on a lifeline. Now that you've had more than 2, then it's lifelong treatments. Now, I've very rarely seen anyone have a 3rd event, but sometimes if that happens, then there's a type of catheter that they put in the superior vena cava, one of the arteries, to help also prevent blood clots. But like I said, I rarely have seen a 3rd event. Eliquis should be all you need to help prevent that from occurring again.
Any other questions, comments, examples? I think we made our way through everything that I saw in the chat and Q&A. All right. Well, if not, I just wanted to say thank you so much for everyone joining this morning. A big thank you to Dr. Kinsey Gotier. We greatly appreciate your time sharing all this incredibly helpful information. We will be sharing both the recording and the slide deck afterwards, so keep an eye out for those. And then if everyone just wants to hang tight real quick, we will wrap up here, and then I want to show you all a resource that we have for everyone, just as a reminder moving forward. So again, thank you so much, and we will see you all next time.